One of the most important things to understand is that not every pterygium requires surgery. Many patients can be managed conservatively with a medical treatment. So, before discussing the surgical techniques, we first need to answer a simple question, and that is, when should a pterygium be operated? The first indication is progressive growth. If the lesion continues enlarging and shows increasing corneal involvement, surgical intervention becomes necessary. The second indication is a visually significant astigmatism or visual impairment. Even before reaching the visual axis, a pterygium can induce corneal distortion and affect visual acuity. The third indication is chronic symptoms despite medical treatment. Patients may continue experiencing irritation, redness, foreign body sensation, or even recurrent inflammation despite adequate conservative management. The fourth indication is cosmetic concern. Large fleshy pterygia may become cosmetically significant and affect quality of life. And the fifth indication is surgical planning. Yes, a significant pterygium can alter keratometry, corneal topography, and even affect the biometry measurements. And therefore, excision may be required before cataract surgery or refractive surgery planning. Before discussing each procedure in detail, let us first look at the major techniques that we will be covering in this video. The first technique is the bare sclera excision. Now, this is the historical procedure and forms the basis for understanding the evolution of pterygium surgery. Next comes the conjunctival autografting, which is currently considered the gold standard treatment for most primary pterygia. Then we shall be discussing the limbal-conjunctival autografts, which incorporate limbal tissue into the graft. After that, we will cover the amniotic membrane transplantation, which is particularly useful in selected clinical scenarios. We will also discuss methods of graft fixations, including sutures and fibrin glue, as well as the adjunctive therapies such as mitomycin C, 5-fluorouracil, and the anti-VEGF agents. Finally, we will also discuss recurrence prevention, post-operative management, and surgical complication. So let us begin with the procedure that started it all, and that is the bare sclera excision. Now, in this procedure, the pterygium tissue is excised from the cornea and conjunctiva, and the underlying sclera is left exposed without placing any graft. The principle behind this procedure is straightforward. You just remove the visible lesion. Because the technique is relatively simple and requires minimal surgical time, it was widely performed in the past. The basic steps here include separation of the pterygium head from the cornea, excision of the fibrovascular tissue beneath the pterygium, removal of the involved conjunctiva, and leaving the scleral bed exposed. Now, although the procedure is technically simple, it has one major limitation, and that is recurrence. Bare sclera excision is associated with significantly higher recurrence rates compared with the modern grafting techniques. And in many cases, the recurrent pterygia that arises may become more vascular, more fibrotic, and more aggressive. And this high recurrence rate ultimately led to the development of newer procedures aimed at reconstructing the ocular surface after excision. Conjunctival autografting is considered the gold standard surgical treatment for most primary pterygia currently. In this procedure, after excision of the pterygium, the bare scleral defect is covered using a healthy conjunctiva harvested from another area of the same eye. The graft is most commonly obtained from the superior bulbar conjunctiva. Now, the obvious question is, why does placing a conjunctival graft reduce recurrence? The answer lies in the mechanisms responsible for the recurrence itself. As we discussed in part 1, pterygium is not simply a localized fibrovascular growth. It is a disease of the ocular surface characterized by chronic inflammation, fibrovascular proliferation, abnormal wound healing, and limbal barrier dysfunction. So, when a pterygium is removed and the sclera is left exposed, Healing occurs through migration of fibroblast, inflammatory cells, and fibrovascular tissue from the surrounding conjunctiva. And this exaggerated wound healing response is something which promotes recurrence. Conjunctival autografting, on the other hand, directly addresses these mechanisms. First, the graft physically covers the exposed scleral bed. This creates a biological barrier that limits the fibrovascular ingrowth from surrounding conjunctiva. Second, the graft reduces the post-operative inflammation also. And an exposed scleral bed triggers a stronger inflammatory response and stimulates the wound healing pathways. In contrast, immediate tissue coverage promotes more physiological healing and reduces the release of inflammatory mediators responsible for fibrovascular proliferation. Third, the graft restores a more normal ocular surface architecture. Instead of healing through scar tissue and fibrovascular overgrowth, the surface heals through normal conjunctival epithelium. This results in a more organized wound healing and less fibrosis. Together, these mechanisms significantly reduce recurrence. While the bare sclera excision may have a recurrence rate ranging from approximately 30 to 80%, conjunctival autografting typically reduces the recurrence to approximately 2 to 15% depending upon the surgical technique, patient factors, and duration of follow up. For this reason, conjunctival autografting became the benchmark procedure against which modern pterygium surgeries are compared now. Now, let us briefly understand the surgical steps. The procedure generally involves excision of the pterygium, preparation of the recipient bed, harvesting a conjunctival graft, transfer of the graft to the recipient site, and then fixation of the graft. We are not going to go into the details of all the surgeries. We are just going to understand the basic step. An important surgical principle is harvesting a thin conjunctival graft with minimal Tenon's tissue. And why is this important? Because Tenon's tissue contains fibroblast and vascular elements that can contribute to post-operative inflammation and fibrosis. And therefore, excessive tenon tissue within the graft may therefore increase recurrence risk. Another important principle is graft orientation. The limbal side of the graft should be positioned adjacent to the limbus of the recipient bed. Maintaining this proper orientation helps preserve the normal ocular surface anatomy and promotes more physiological healing. Despite its excellent results, recurrence can still occur, particularly in younger patients who have more inflammation, in active fleshy pterygia, if there is chronic ultraviolet exposure, persistent ocular surface inflammation, and inadequate surgical techniques like not preparing the bed adequately, not removing the Tenon's tissue. So, while conjunctival autografting restores the conjunctival barrier and significantly reduces recurrence, another question arises: can recurrence be reduced even further by restoring the limbal stem cell barrier itself? And this brings us to the next procedure, that is the limbal conjunctival autograft. Before discussing this procedure, it is important to understand the difference between a conjunctival autograft and a limbal conjunctival autograft. In a standard conjunctival autograft, only the conjunctival tissue is harvested and transplanted to cover the scleral defect. In contrast, a limbal autograft or a limbal conjunctival autograft includes not only the conjunctiva but also a small segment of limbal tissue at the edge of the graft, and therefore both procedures reconstruct the ocular surface. However, the limbal conjunctival autograft additionally attempts to restore the limbal barrier. As we discussed in part 1, the limbus normally acts as a biological barrier between the conjunctiva and the cornea, preventing the growth of conjunctiva over the cornea. When this barrier becomes compromised, conjunctival tissue can now migrate onto the corneal surface, contributing to pterygium formation and recurrence. So, the objective of the limbal conjunctival autograft is therefore to cover the scleral defect, reconstruct the ocular surface, restore the limbal barrier, reduce fibrovascular ingrowth, and further reduce the recurrence. Let's look at its basic steps. The procedure involves excision of the pterygium, preparation of the recipient bed, harvesting a conjunctival graft containing a small segment of limbal tissue. It can be taken from superior or from the superior temporal location. Transfer of the graft to the recipient site, alignment of the limbal portion with the recipient limbus, and fixation of the graft. The reported recurrence rates are generally low and are often in the range of approximately 1 to 10%, although the results may vary between studies and surgical techniques. So far, we have discussed the conjunctival autografts and the limbal conjunctival autografts. Both procedures require harvesting healthy conjunctival tissue from the same eye. However, there are situations where preservation of the conjunctiva becomes important. For example, in large conjunctival defects, patients with recurrent pterygia, patients with bilateral pterygia, or patients with bi-headed pterygia, conjunctival scarring, limited healthy conjunctiva, patients who may require future glaucoma filtration surgery. So, in such situations, another reconstructive option becomes valuable, and that is the amniotic membrane transplantation. The amniotic membrane is the innermost layer of the placenta. It is obtained from carefully screened donors, processed under sterile conditions, and preserved for ophthalmic use. Structurally, the amniotic membrane consists of a basement membrane, which is supported by an avascular stromal matrix. So you just have a basement membrane and an avascular stroma. This acts as a biological scaffold for ocular surface healing. Now, an important question arises: why does the amniotic membrane help? The answer lies in its biological properties. The membrane promotes epithelial healing, it suppresses inflammation, it reduces fibrosis, and creates a more favorable environment for ocular surface reconstruction. For this reason, the amniotic membrane has become an important tool in the ocular surface surgery. Following the pterygium excision, the amniotic membrane is placed over the scleral defect and secured in the position. The objectives of the amniotic membrane, therefore, is to cover the exposed sclera, promote epithelial healing, act as a scaffold, reduce inflammation, reduce fibrosis, and support the ocular surface reconstruction. Unlike a conjunctival autograft, the amniotic membrane does not provide the conjunctival tissue. And unlike the limbal conjunctival autograft, it does not restore the limbal stem cell barrier. This is an important limitation to remember. The conjunctival autografting generally provides a superior recurrence control compared with the amniotic membrane transplantation, and therefore, for most primary pterygia, limbal conjunctival autografting or conjunctival autografting remains the preferred procedure. Amniotic membrane transplantation is usually reserved for selected cases where preservation of the conjunctiva or ocular surface reconstruction becomes particularly important. Now, regardless of whether we use a conjunctival graft, a limbal conjunctival graft, or an amniotic membrane graft, another important question remains: how do we basically secure the graft? And this brings us to the graft fixation techniques. Graft fixation can be achieved using either sutures or the fibrin glue. Let us first discuss the sutures. Traditionally, a graft fixation was performed using fine microsurgical sutures. Commonly used were the absorbable 80 vicryl or the non-absorbable types 10-0 nylon. The exact technique varies between surgeons. Most commonly, the interrupted sutures were placed at the corners or at the edges of the graft, and typically approximately 4 to 8 sutures are used depending upon the size of the graft and the surgeon's preference. The knots should be rotated or buried away from the corneal surface whenever possible to reduce post-operative irritation and foreign body sensation. If non-absorbable nylon sutures are used, they are typically removed after adequate graft adherence, usually around 1 to 3 weeks post-operatively, depending upon the healing and surgeon's preference. Absorbable vicral sutures do not require removal and they gradually dissolve over time. Now let us discuss the fibrin glue. Fibrin glue is nothing but it's a biological tissue adhesive which is composed primarily of fibrinogen and thrombin. So when we mix these two together, these components form a fibrin clot that acts as a temporary biological adhesive. Essentially, the fibrin glue mimics the final stages of the body's natural coagulation cascade. After preparing the recipient bed, a small amount of fibrin glue is applied and the graft is carefully positioned over the defect. Now let us compare the two fixation methods, sutures versus the fibrin glue. The advantages of sutures include, they're widely available, they're of lower cost. However, sutures produce foreign body sensation, post-operative discomfort, local inflammation, and suture-related irritation. In addition, the suture placement increases the surgical time. Fibrin glue advantages include reduced surgical time, improved patient comfort, less post-operative irritation, inflammation will be less, and also faster recovery. However, fibrin glue has limitations too. It includes higher cost, limited availability in some settings, and risk of graft displacement if positioning is inadequate. Now, important question is, does the method of fixation affect recurrence? Now, most studies report comparable recurrence rates between suture and fibrin glue, although fibrin glue is often associated with reduced postoperative inflammation and greater patient comfort. Now, even with the modern grafting techniques, recurrence can still occur. So, this brings us to another important aspect of pterygium surgery, and that is the usage of adjunctive therapies for recurrence prevention. The most important adjunctive therapy used in pterygium surgery is mitomycin C. To understand how mitomycin C works, let us try to remember why recurrence occurs. After pterygium excision, the eye attempts to heal the surgical wound. During this process, the fibroblasts proliferate, new vessels form, scar tissue develops, and fibrovascular tissue also may regrow. These are the same process that contribute to recurrence. Mitomycin C works by suppressing this excessive wound healing response. In simple terms, it slows down the fibroblasts responsible for fibrosis and fibrovascular proliferation. So, as a result, there will be less scarring, there is less fibrovascular regrowth, and there is less recurrence rates. Mitomycin C as a drug is most commonly used intraoperatively. After pterygium excision, small surgical sponges which are soaked in mitomycin C are placed directly over the bare scleral bed. Commonly used concentrations include 0.02% and 0.04%, and the duration of application is typically 1 to 3 minutes. After adequate exposure, the area is thoroughly irrigated with the balanced salt solution. Now, although mitomycin C can significantly reduce recurrence, excessive suppression of healing can create complication. And these potential complications include delayed epithelial healing. For example, sometimes what happens is that when you remove the head of pterygium, there will obviously be a corneal epithelial defect. If you use mitomycin C, the epithelial healing gets delayed. Other complications include scleral thinning, scleral melting, other corneal complications, and secondary infections. For this reason, careful dosing and patient selection are important. Another antimetabolite that has been used is 5-fluorouracil. Like the mitomycin C, 5-fluorouracil works by suppressing the rapidly proliferating fibroblasts and reducing excessive wound healing. However, it is used less commonly than mitomycin C in modern pterygium surgery. 5-fluorouracil may be administered intraoperatively or may be administered post-operative subconjunctival injections in selected recurrent cases. Commonly reported doses here include 5 mg dose given as a subconjunctival injection near the recurrence site. However, the protocols can vary considerably between studies. More recently, anti-VEGF agents have also been investigated. These include the bevacizumab and the ranibizumab. Why might the anti-VEGF therapy help? Because pterygium is a highly vascular lesion. VEGF stimulates new blood vessel formation, and by blocking the VEGF, these agents attempt to reduce vascularity, inflammation, and fibrovascular proliferation. Anti-VEGF therapy is most commonly administered as a subconjunctival injection around the pterygium or the recurrence sites. Although anti-VEGF therapy can reduce vascularity, long-term recurrence control has generally been less predictable than with mitomycin C, and therefore anti-VEGF agents are usually considered adjunctive therapies rather than the primary recurrence prevention therapies. Let's talk about the post-operative management and follow-up. Successful pterygium surgery does not end in the operating room. Post-operative care plays a very important role in the survival of the graft, ocular surface healing, patient comfort, and recurrence prevention. Let us discuss the key components of the post-operative management. The first objective is control of inflammation. Following surgery, patients are typically prescribed topical corticosteroids to suppress postoperative inflammation and reduce the wound healing response that may contribute to recurrence. Commonly used agents include prednisolone acetate, loteprednol, fluorometholone. The exact regimen varies again according to the surgeon's preference and individual patient factors. Steroids are usually tapered gradually over several weeks. The second objective is ocular surface support. Lubricating eye drops are commonly prescribed here to improve comfort, to support the epithelial healing, to stabilize the tear film, and to reduce surface irritation. The next important step is monitoring the graft integrity. During the follow up visits, attention should be paid to the position of the graft, whether the graft is at place or displaced, edema, graft retraction, graft dehiscence, that is, breakdown of the graft, and any signs of infection. In the early postoperative period, mild graft edema or conjunctival hyperemia are common and usually they improve gradually. Now let us discuss sutures. If absorbable sutures such as 80 vicryl have been used, they gradually dissolve and generally do not require removal. But if a non-absorbable suture such as 10-0 nylon has been used, they are typically removed after adequate graft adherence, often within 1 to 3 weeks, depending upon healing and surgeon's preference. Also, now let us return to one of the most important themes from part 1 of pterygium lecture, ultraviolet exposure. Even after successful surgery, continued ultraviolet exposure remains a risk factor for recurrence, and therefore patients should be advised to use ultraviolet protective sunglasses, minimize excessive sun exposure, and continue ocular surface optimization. Although modern surgical techniques have significantly improved outcomes, complications can still occur. The most important long term complication is recurrence. As we discussed earlier, recurrence refers to the regrowth of the fibrovascular tissue across the limbus onto the cornea following surgery. The problem with recurrent pterygia is that they are more vascular, they are more fibrotic, and they are more difficult to manage than the primary lesions, and their management depends upon severity. Small, stable recurrences may be observed, whereas progressive or visually significant recurrent pterygium often require a repeat surgery, frequently combined with a conjunctival or a limbal conjunctival autograft with amniotic membrane graft, and also an adjunctive mitomycin C. Let's also discuss the graft related complications. One of the most common early postoperative findings is graft edema. Mild graft edema is expected during the early postoperative period and usually it resolves spontaneously. Management here includes observation, lubrication, and continuation of routine postoperative anti inflammatory therapy. Another complication is graft retraction. This occurs when the graft contracts and fails to adequately cover the scleral defect. So, that is called graft retraction. Small areas of retraction may still be observed. However, if there is significant retraction with exposed sclera, this may occasionally require surgical revision or repeat grafting. A more serious complication is graft dehiscence or graft loss. This may result from inadequate fixation or the patient having excessive eye rubbing problem, early graft replacement, poor healing. So minor dehiscence may sometimes be managed conservatively. However, significant graft displacement or graft loss often requires repositioning or repeat grafting. Then we have suture-related complications like foreign body sensation, ocular irritation, local inflammation, and even suture granuloma formation. Here, the management includes lubrication, topical anti-inflammatory therapy, and removal of the offending sutures when appropriate. Another important complication occasionally encountered is the conjunctival granuloma. This represents an exaggerated inflammatory response and may appear as a small vascular conjunctival mass near the surgical site. Small granulomas may respond to topical corticosteroids. However, persistent or symptomatic lesions may require surgical excision. We already discussed the complications associated with mitomycin C, and here the management depends upon the severity of complication. Excessive lubrication or ocular surface support is required. If there is severe scleral thinning or scleral melt that requires surgical intervention, including a patch graft. So, before concluding, let us summarize some practical surgical pearls that every ophthalmologist should remember. Pearl number one: not every pterygium requires surgery. Pearl number two: pterygium surgery is not simply lesion removal, it is an ocular surface reconstruction. The objective is not only to excise the fibrovascular tissue but also to create an environment that will minimize recurrence. Pearl number three: bare sclera excision alone is associated with unacceptably high recurrence rates and is now largely of historical importance. Modern surgeries rely on reconstruction of ocular surface following excision. Pearl number four: for most primary pterygia, a limbal conjunctival autograft remains the gold standard treatment or procedure. It provides excellent outcomes and significantly reduces the recurrence compared with the bare sclera excision. Pearl number five: when harvesting a graft, take a thin graft with minimal tenons tissue. Excessive tenons tissue may increase postoperative inflammation, fibrosis, and recurrence. Pearl number six: always pay attention to the orientation of the graft. The limbal edge of the graft should be positioned adjacent to the recipient limbus. Proper orientation contributes to more physiological ocular surface healing. Pearl number seven: recurrence is fundamentally a wound healing problem. So, anything that increases postoperative inflammation, fibroblast proliferation, or fibrovascular growth may increase the recurrence risk. Conversely, meticulous surgery, careful tissue handling, adequate graft fixation, appropriate use of adjunctive therapies help reduce recurrence. Pearl number eight: do not forget the importance of ultraviolet protection. Even after successful surgery, continued UV exposure remains an important risk factor for recurrence.